Hello everyone, and thank you for watching this video. This video is about respiratory distress in newborn. So let's say you are on your pediatrics rotation and you are assisting a pediatrician and he's in the labor room and he's just seeing a newborn that has been just delivered, and what you see is that the newborn is having some respiratory distress. So then a lot of things starts going to your mind. But first of all, you need to recognize what actually is respiratory distress. So what is respiratory distress and how do you identify that this newborn is having a respiratory distress? So the things that you should look for is flaring of the nostrils. This is what I'm showing over here is the retractions that you can see in the intercostal spaces. These are all the signs of the newborn having some distress. Now here is a good summary of all the retractions that you can observe, that you can possibly observe, this being the suprasternal, intercostal retractions, and substernal and subcostal retraction. You can also hear a grunting sound in the newborn, which also would indicate a respiratory distress. So now you think, what does this baby has? Now you start going through the differential diagnosis of the respiratory distress. So what I would like to think of, first of all, that is this baby term, preterm, or is this baby post-term? Did the mother have any risk factors associated with the respiratory distress? Like, did she have maternal diabetes mellitus? Was she having preeclampsia? All these factors come into account when you're thinking about a diagnosis. So let's start. If the baby is preterm, you should think of respiratory distress syndrome. And if the baby is at term, you should think of transient tachynea of the newborn. And if it is term plus post-term, you think of persistent pulmonary hypertension and meconium aspiration syndrome. Don't worry, I'm going to explain all of this in a good detail. So first of all, starting with what is respiratory distress syndrome, which is also known as hyaline membrane disease. We are going to go through why this is called hyaline membrane disease in just a little while. So what I'm trying to explain over here is that, as you can see, this thing over here is the surfactant. So basically, respiratory distress syndrome is nothing but a deficiency in the surfactant. So as you can see, this, when you're inspiring, this is the amount of air that is coming, and this is opening up the alveoli. So this is the surfactant, and when you exhale out, the alveoli start to collapse, and to prevent them from collapsing completely, we have to have surfactant, as you can see, to exert a pressure on the alveoli from it to collapse. So when you do not have the surfactant, this is what your alveoli is going to go into, that is called collapsed. It is going to get collapsed because when you exhale, there is an increased amount of positive pressure that is generated, and you collapse your alveoli in the absence of surfactant. So why do you need surfactant? To keep that surface tension away from the alveoli, and to keep it contracting and relaxing at the same time when you're inhaling and exhaling. So what is surfactant? Surfactant is a lipoprotein which is having two components, first being the phosphatidylcholine and second being phosphatidylglycerol. Now these, both of them are produced by type 2 pneumocyte. This is an high yield association. You have to remember that this is being produced by type 2 pneumocytes. So what is the pathophysiology? I said we do not have surfactant available. So what? Now within the next inspiration, you would not be able to adequately take the O2. So you can see over here the alveoli is collapsed, so you cannot expand the alveoli and you cannot process the O2 from the alveoli into the capillaries that you have. So what will happen is, if you do not have enough amount of oxygen happen is the pulmonary vasculature is going to go into vasoconstriction. You might be thinking this is so stupid of lungs that they go into vasoconstriction when you don't have oxygen. They should rather dilate, which is what actually happens in rest of the organ system in a body. When you don't get enough oxygen, there is a vasodilation so that you get increased amount of blood flow and you take up a lot of more oxygen from there. But this is actually a protective mechanism in the lung, which I'm going to explain in a little while. So this is because that the lung is trying to shunt the deoxygenated blood from a bad area over here to a good area so that the capillaries can pick up the oxygenated air from other area which are good, so you avoid the area. So it's like you avoid going to bad places, but you actually go to good places to get good stuff. So the more blood is shunted to good area, and the area which does not have enough amount of oxygen gets little amount of blood. So coming forward, the pulmonary vasculature goes into vasoconstriction, which would further increase the pulmonary venous pressure. Remember, the right ventricle empties into the pulmonary vein, so the pulmonary veins pressure is going to go up. What it is going to do is that, you see, this is the pulmonary vein over here. If you have increased pressure over here, the blood is going to go back up from the right ventricle into the right atrium, and then into from the foramina ovale, which is still patent in the newborn, for a little amount of time. It goes into the left atrium and then into the left ventricle and into the system by aorta. So what does this happens is you get mixing of the deoxygenated blood into the oxygenated blood, and you develop cyanosis, and the tissues don't get enough amount of oxygen, which further leads to hypoxia. And if this persists for a longer time, it can lead to respiratory failure. So this is a graph which I want to explain you guys, that at 20 weeks of gestation in the amniotic fluid, the phosphatidylcholine, which is also known as lecithin, is starting to produce, which is the surfactant that we want in our alveoli. And at around 33 to 30 week, its concentration starts to peak. Whereas the sphingomyelin, which is another component which stays constant at this time. So by doing some research, we have found out that lecithin to sphingomyelin ratio of more than or equals to 2 indicates that there is an adequate surfactant production. And how do you measure this? By measuring the amniotic fluid concentration of these two substances. So if the ratio is less than 2, let's say 1.5, that would indicate that the baby does not have a good amount of surfactant production. So now this is an X-ray showing you that if you do an X-ray later on while you have resuscitated the patient, this is what an X-ray of respiratory distress is going to look like. You can see the ground glass opacities, which are also known as reticulogranular opacities, and these are called air bronchograms. You have this area of black and all surrounding area of white. So this is called air bronchograms. Do Google all this stuff and you'll get a very good clear picture about this, and you'll be able to type very easily. Now what you do for these patients? Okay, before that I want to discuss that why, if the mother is having maternal diabetes, the baby is at increased risk for respiratory distress syndrome. Basically because in maternal diabetes you have high amount of glucose that is being transferred from mother to the baby, and the baby is having a high amount of glucose, but the pancreas in the neonate is absolutely fine, so they are going to tackle this high amount of glucose by producing increased amount of insulin. Now what does insulin do is it inhibits the production of surfactant. So if you have maternal diabetes, the baby is going to have decreased amount of surfactant production because there is an increased insulin present. So this is the pathophysiology, and this is absolutely high yield. You should know this. And how can you prevent this? By giving the mother antenatally corticosteroids. And corticosteroids, to your surprise, increases the production of surfactant. So if you know that the mother is going to deliver prematurely, you can give the mother glucocorticoids to increase the maturity of the surfactant production and increase the maturity of the lungs. So we have a normal histology of the lung tissue over here, because the next slide is going to be about the hyaline membranes. So you can see this increased amount of pink colored things over here. I have underlined this over here. So this is why it is called hyaline membrane disease. Anytime you read hyaline in pathology, that means red, or it might mean pink. You can see over here pink membrane that are lining the alveolar spaces. Now you might be thinking, how did this form? These are all proteins which have come out of the capillaries. Now let me remind you that the alveoli have been collapsed, and the basement membrane that the alveoli has, it is also collapsed. So the fluid exchange from the capillaries that is connected to the alveoli starts increasing, because they all are going to die. They would not get enough oxygen. So the proteins that are present in the capillaries goes out, and then they form the hyaline membrane, which is itself a protein substance. So that is why it is also known as hyaline membrane disease. Now, how do you treat these patients? Is by providing them continuous positive airway pressure. Now, how does this work? Is it, you can see the alveoli in respiratory distress syndrome, and you continuously keep the alveoli distended by providing a continuous positive airway pressure. And you can also give endotracheally surfactant, so that it would replace the deficient amount of surfactants present in the alveoli. So this is all about respiratory distress syndrome. Now coming to transient tachypnea of the newborn. This is kind of self-explanatory. You see the word transient tachypnea. So the baby is going to have increased RR. But before that, you should know what is the normal RR. The normal RR being 30 to 60 breaths per minute. So if you recall, when the baby is in the womb of the mother, the amount of blood coming into the right atrium, going into the right ventricle, and then from pulmonary arteries, it is shunted back into the system by patent ductus arteriosus. No, I'm sorry, not patent ductus, by ductus arteriosus. And very little amount of blood goes into the lung. So because there is an increased pressure in the lung, and the lungs are already filled with fluid, so when the baby is born, it takes its first breath, and what happens is all the fluid that is present in the alveoli goes out from the alveoli, so that the oxygen can be adequately come into the alveoli. But what is happening in transient tachypnea of newborn is that this fluid is going slowly out of the alveoli, and it is taking a little more time than the usual. That is why it is called transient, because it is eventually going to go out, but this is going a little slowly. So the baby is experiencing tachypnea. Now this would actually resolve in 2 days, which is why it is also called transient. And how do you recognize that this was a transient tachypnea of newborn? When you do a chest x-ray, you are going to find a bilateral, that is, both the lung fields would have a perihilar linear, means horizontal streaking. I could not find a good image of this, so I'm just trying to explain it over here. This is the hilar regions, and you would find in a linear streaking near the hilar region in both the lung field. So this is about transient tachypnea of the newborn. This would also present as respiratory distress in the newborn, but this would resolve in 2 days. Now coming to persistent pulmonary hypertension. So as I said in the previous slide, that there is a increased amount of resistance in the pulmonary vessels when the baby is in the womb. So if that pressure persists, that would lead to persistent pulmonary hypertension. Now manifest is same as the respiratory distress syndrome and transient tachypnea of the newborn. The baby is going to have respiratory distress plus it is going to have marked cyanosis. Why? Because you are having an increased pressure in the pulmonary venous system. So the blood is going to go back up from here and into the foramen oval and then again into the systemic circulation. So you are having shunting of blood, which is deoxygenated blood mixing with oxygenated blood. So but obviously you're gonna see cyanosis. And what do you see on the chest x-ray is you have clear lungs with decreased pulmonary vessel markings. For that I want to show you a normal pulmonary markings. You see the white, small white things over here, these are all pulmonary vessels. Over here I've marked them. So when you have persistent pulmonary hypertension, you have decreased amount of pulmonary markings over here. You can see all blackout area which does not show any vessels. All this is air. So this is persistent pulmonary hypertension. The treatment of that is beyond the scope of this video. So coming on to the next topic, which is if you have a baby that is postpartum, which means more than 42 weeks, what do you think of is meconium aspiration syndrome. Now it is self-explanatory that more the time the baby spends in the womb, that is the uterus, it is likely to aspirate its own excreta. So if you see in the question that they described that the meconium was not clear, which it has to be clear. If the meconium was not clear, the baby is likely to have aspirated that meconium and it has developed meconium aspiration syndrome. And how do you identify that on chest x-ray is by looking at this patchy infiltrates in both the lung fields, which are numerous in number. Diaphragm can also appear flat, but this is not the case in this chest x-ray. So you can easily differentiate all of these from respiratory distress syndrome, which would have an air bronchogram and ground glass opacity, persistent pulmonary hypertension, which would have clear lung fields, and this is meconium aspiration syndrome, which is having fluffy patchy infiltrates in both the lung fields. And this is a summary table of all the things that we have discussed. This is transient tachypnea of newborn, which is due to inadequate fluid clearance in the alveoli. This is RDS, which we do not have no surfactant, and persistent pulmonary hypertension is because you have high pulmonary pressure, which will lead to shunting of blood from right side to the left side. Now, bilateral perihilar linear staking will be observed in transient tachypnea of newborn. Diffuse ground glass and also known as reticulogranular opacity is in RDS, and air bronchograms is also present. Persistent pulmonary would have clear lungs with decreased vasculature that we just saw. And meconium aspiration is going to have bilateral fluffy patchy infiltrates. Now this can also be one of the differentials, but I did not explain this in detail. But the most likely clues that you can see in the baby is that the abdomen is going to be more scaphoid, that it can also be framed as more concave, and it is most likely on the left side because on the right side you have liver. So left side is a pretty good place to displace your bowels into your lungs. So what is that going to lead to is it is going to compress on the left side of the lung field. See the lung becoming so small, and all this loop left side you can observe. So what happens is lung becomes so small that they do not function well. So how do you treat this babies is that you do an endotracheal intubation. Now you must be thinking, why do endotracheal intubation? Why not do a face mask ventilation? Because if you put in more air into the stomach, it is eventually going to go into intestine, and the intestines are going to blow up more and they are going to press upon the lungs. So doing that is going to worsen the respiratory distress in the baby. So you directly have to put in the lungs into the so you directly have to put in the air into the lungs via an endotracheal intubation. You can also not give continuous positive pressure because that is not going to help either. You have to do endotracheal intubation first. So that is all. So thank you for watching. If you like this video, give it a thumbs up.